there?
Yeah, I am here.
Yeah.
Okay,
We'll be starting with 1 minute. Okay. So
we are live.
We are live. YouTube live.
Yes.
Done.
Yes,
Yeah,
yes.
done. Okay. So you just mute all. I'll tell sir to unmute. Sir, you can unmute yourself because after the introduction, I can hand over the session to you. Right,
yeah,
sir?
I unmuted myself.
Yeah. Right, sir. Right. So, Santosh, you can open the PPT.
Yes, Dada.
Yeah. Yeah, so it's a 7 o'clock. So I'll give an introduction of yourself, and you can start the session, right? So I'll just go. Good evening, doctor. I, Chayan Majumdar, on behalf of Jaidas, welcome you in IBS Gurukul. As you know, doctor, IBS symptom manifestation is varied patient to patient. We believe a practical approach to manage IBS is important in your day-to-day practice. It's my pleasure to have Dr. Jyoti Ranjan Mohapatra as a speaker of today's IBS Gurukul. He is a consultant gastroenterologist at PLS Hospital, Kolkata. He has 34 years of excellence in the field of gastroenterology, a scholar, and a gold medalist in medicine and surgery. He was a presenter in various conferences such as BSG, AGA, and Gastrointestinal Masterclass at Belgium. His articles were published in numerous national and international journals. Once again, we believe today's IBS Gurukul will be useful in your day-to-day practice. During the webinar, you can post your question in the chat box. Now I request Dr. Jyoti Ranjan Mohapatra to start today's IBS Gurukul. Over to you, sir.
Good evening to all. I know this is a pleasant task to talk about irritable bowel syndrome. I am really pleased that I have been asked to talk about this IBS Gurukul. I am grateful to Jaidas for their endeavor for this talk. So what I'll do is I'll just switch off my video so that it becomes a smooth running process. So and start sharing the screen. Okay, is my slides visible?
Sir, your slide is visible.
Okay.
Sir, is there any connection issue over there?
No, it's okay.
So,
No.
Sir, you can also
switch on my video.
Yes, because the people who are joining, the doctors who are joining, they would like to see you also.
Okay,
right?
okay. I'll just then stop share and start again.
No. Sir, you share the screen and you switch on your video. That's
okay.
all.
Okay.
Both will be working.
Okay.
Yes, sir. Done, sir. Done.
Okay, my video is visible now.
Yeah. You are visible and your slide is visible also.
Okay. So I have been assigned the talk about irritable bowel syndrome or the critical approach because this illness is such an illness. It is never critical, but the doctor feels critical about the illness and the patient feels critical about whole illness. Once they come to you, you feel very irritated because they come and again. First thing they start is that, sir, I am not getting well. This is the first statement when you hear in a clinic that this is the statement that I am not well despite your treatment. I have come to you so many times, but I am not getting better. So as such, patient gets irritated by so many times coming, not getting better, and you also feel that you are not doing a good job, and the patient is just, you may end up ending and referring to the psychiatrist. So that happens in a day-to-day scenario. I'll just start off with a case. So is a 38-year-old woman with pain, bloating, and loose stools. The underlying fact is that she has got pain, bloating, and loose stools. When I'll tell you the definition of IBS, I'll tell how these things are important. The onset of abdominal pain, bloating, and gas, loose stool on occasions for about 15 years. Important. This is 15 years. It's not 1 month or so. It's a not short history, longer history, 15 years, but more frequent for the last 4 to 5 years. So recent aggravation of the symptom is 4 to 5 years, not very suddenly patient has changed the bowel and is losing weight or something, she's losing weight or thing. It's a chronic kind of symptom patient is having, and worse, so to say, for last 4 to 5 years. I am going a little bit slow, hopefully. So symptoms often occur after eating. Bowel movement frequency is 2 times per day on days without pain, but increases up to 6 times with pain about 3 days per week. Important underlying fact is 3 days per week, not every day, not once a week or less than once per week. It's 3 days per week. Stools are formed on good days and become progressively looser and watery on bad days. So this is the consistency which is changing. Abdominal pain is located bilaterally in the lower quadrant and relieved after passing several bowel movements. The patients avoid leaving home in the his fear that patient, because of her symptoms that can aggravate, because she has to eat outside and she has to go to the toilet after fooding because of the postprandial feeling like going to the defecation or the gastrocolic reflex. She denies bleeding, nocturnal diarrhea and weight loss. There is no family history of colon cancer, important celiac disease, IBD, inflammatory bowel disease, but father and sister have occasional pain and diarrhea, but have not sought medical attention because their symptoms are not very significant to seek medical attention. On examination, there was a mild abdominal distension and tenderness of the right lower quadrant. Stool is negative for occult blood, and gastroenterologists have already performed routine laboratory studies. Celiac serologies have been done, colonoscopy with random biopsies, all of which were normal. Colonoscopy was normal, as well as the biopsy to rule out microscopic colitis was also normal. So how to go further in such scenario? So looking at the history, physical examination, colonoscopy, all these things, and the family history, there is nothing like cancer. So how do you go further on this scenario? So evolution of mechanics of IBS, what is the pathophysiology of IBS? It started with 1950, abnormal motility was only considered in 1950. But when progressively we learned more about IBS, by the year 2000, we learned that 5-hydroxytryptamine or serotonin mediated visceral sensitivity and gut motility takes a vital step. So in between, there could be senses like visceral hypersensitivity, brain-gut interaction, gut-brain interaction, whatever you say. This is the second brain. Gut is the second brain because of the myenteric plexus and the airbags plexus that in the gut. So this again, because of the autonomic nervous system, we consider gut as a second gut. So brain-gut interaction. And finally, we are now at the point where the 5-HT is mediated visceral sensitivity and gut motility causing diarrhea and pain. So this is the evolution. So what about irritable bowel syndrome? I already mentioned there are certain psychosocial factors, and there could be leading to altered motility or can lead to altered sensorium. Altered motility will cause altered sensorium, and it's a vice versa. Altered sensorium cause psychosocial factor. Psychosocial will cause altered sensorium. Because once they have got this problem, this goes on like a cycle. The one thing makes the other thing worse, and the other thing makes the one initial thing worse. So biopsychosocial disorders have been already mentioned. Psychosocial things are like motility, sensory, and could be infectious. People used to tell as infectious IBS. This is not, the nomenclature is wrong. There is nothing called infectious IBS. We called infection IBS, infection associated IBS, and post-infection IBS. We called it, now the terminology after Rome 4 has been changed. This is called post-infection IBS, because this IBS is never an infectious disease. If you have got IBS, you cannot transmit to others. So this nomenclature infectious is a wrong nomenclature. This is post-infection IBS. Prevalence of 10%, incidence of 1 to 2 per year, disturbs the quality of life, social function, healthcare utilization. It takes lots of cost of money of the healthcare for this. So coming to the pathophysiological model, this is the psychosocial factor like life stress in the family, in the circumstance, in the employees surroundings, psychological state like coping with everyone, social support system, all could be factored in psychosocial factors that can lead to IBS symptom, or IBS symptoms can make the psychosocial factors worse. Because someone has got IBS symptom, very difficult to cope with the work environment, very difficult to cope in the family, very difficult to cope in the social support system. So what about genetics, environment, bacterial flora, food hypersensitivity? They have some role, as well as these things, psychological, all these things have role. So what happens in toto, that in final endpoint physiology is altered, like motility as well as sensation is altered. And what can change the outcome are medication, frequent surgery visits, daily function assessment, and quality of life. So all these things could change the outcome in these patients. So what is the current thinking on pathophysiology? Defects in the enteric nervous system may lead to hallmark symptoms of IBS. There are two things. One is visceral hypersensitivity, increased visceral afferent response to normal as well as noxious stimuli. Mediators include 5-hydroxytryptamine, bradykinin, that is 5-HT serotonin, bradykinin, tachykinin, CGRP, and neutrophils. Primary motility disorders of the GI tract could be mediated by 5-HT, acetylcholine, ATP, motilin, somatostatin, nitric oxide, substance P, and VIP. So this everything could be causative in visceral hypersensitivity as well as primary motility disorder. But one thing that is very common in both is 5-hydroxytryptamine, that is serotonin. That is the pathophysiological basis. This is the latest concept that we have all our products, either prokinetics or treatment for diarrhea. We want to decrease the motility, then you use this serotonin receptor antagonist or agonist. This is the physiological distribution of 5-HT. 5-HT is distributed in CNS only 5%. But look at the gastrointestinal tract. Gastrointestinal tract has 95% of 5-HT. And because they are enterochromaffin cells as well as the neuronal tissue have got this 5-HT in the intestine. So it mediates the reflex controlling GI motility and secretion. It mediates perception of the visceral pain. So pain and secretion, that is causing increasing motility and secretion. So that is the pathophysiology behind the diarrhea predominant IBS. I'll tell you what is diarrhea predominant IBS and what is constipation. And visceral pain is one of the hallmark features that is mediated by perception with 5-HT receptors. So comparison of pain threshold of IBS patients and controls. Pain produced by rectosigmoid balloon distension. Look at this red line or purple line. This is the normal. If we go on increasing the air insufflation, more than 150 cc or 200 cc, it can cause pain. This is the 180 mark. More than 150 cc, you can get the pain. Look at the patients with the IBS. The patients start pain even with a 20 ml, 30 ml of air. That means when you are doing colonoscopy, even if you start the examination of the rectum with a small amount of air, the IBS patient will always complain that I am getting pain from the beginning. But if a normal subject will not get pain unless you are distending a large volume of air. This is one of the characteristics during colonoscopy. You can tell that this could be patient with irritable bowel syndrome. Once the colonoscopy is normal, you can generally clinch that this could be irritable bowel syndrome. So what is the comparison of pain threshold? Because they have tested two things. One is colonic distension by balloon. Other one is ice water immersion. This blue depicts the IBS and the white depicts the normal. Look at this. In IBS, with a small amount of distension, there is pain. But with ice water immersion in IBS, there will have pain. So this is the comparison with small distension and ice water immersion. IBS patients will have pain. So previously, we used to think IBS is a diagnosis of exclusion, but nowadays we make a positive diagnosis of IBS because identify the abdominal pain as a dominant symptom with altered bowel function. Look for red flag signs. What are the red flag signs? I'll tell you. Perform a diagnostic test or physical examination if the red flag signs are present to rule out the organic disease. You can make or confirm a diagnosis, initiate treatment program as part of the diagnostic protocol, and you should follow up in every 3 to 6 weeks. So these are the red flag signs, may suggest alternative or coexisting disease. Additional diagnostic training needed for atypical presentations such as anemia, fever, persistent diarrhea, rectal bleeding, severe constipation, or weight loss. If there are nocturnal symptoms, someone having nocturnal diarrhea, pain or abnormal bowel function, if there is a family history of GI cancer, inflammatory bowel disease or celiac disease, you should question yourself whether you're dealing with IBS or not. New onset of symptom in elderly, that's if someone is also 50 plus years of age in Indian context, we think of malignancy because we find a lot of young people with the malignancy, GI malignancy, especially colonic malignancy in their Indian scenario. For elderly people in Western world, this may not be the same as we get in India. India, we get it at lesser age, this malignancy. So these are the red flag signs on physical examination, history, physical examination, initial laboratory test. On physical examination, if you find abnormal, for example, a lump in the abdomen, if there is a fever, if there is a positive occult blood, this is also investigation. Historically, you can get weight loss, onset in older patients, nocturnal awakening, nocturnal diarrhea someone is getting, family history of cancer or IBD. Initial laboratory tests like low hemoglobin, increasing WBC suggesting infection, ESR or CRP suggesting inflammation, or there could be abnormal biochemistry. All these are red flag signs which needs to be investigated early instead of giving them a therapeutic trial. So these are the differential diagnosis. One is there could be lactose intolerance, caffeine intolerance, alcohol, fat, gas-producing foods. There could be infection like Giardia lamblia, bacterial or amoeba, inflammatory bowel disease already mentioned, ulcerative colitis, Crohn's, microscopic and mast cell disease. There could be psychological factor like anxiety, panic, depression, or somatization. There could be miscellaneous like endometriosis, endocrine tumor like carcinoid, VIPomas, and AIDS. There could be malabsorption like post-gastrectomy malabsorption, intestinal cause or pancreatic cause of malabsorption. Sometimes there could be small intestinal bacterial overgrowth, which can be treated with antibiotics. So what is the diagnostic approach? Once you have got a patient with the IBS, you establish a symptom-based diagnosis. You make identify dominant symptom like pain, diarrhea, or constipation. If diarrhea, treat diarrhea. Constipation, treat constipation. Consider other clinical factors which is contributing to this IBS. You can perform a diagnostic test and initiate the treatment, but reassessment in 3 to 6 weeks. Not once you start treatment, ask them to come after 6 months or so. They have to be periodically reassessed about the drugs and how they are behaving with the quality of life and how they are behaving with the drugs. So this is the Rome 4 criteria. Recurrent abdominal pain on average at least 1 day per week in the last 3 months associated with the 2 or more of the following. What is the 2? Related to defecation and or associated with change in stool frequency, important is frequency, or appearance, the stool form should change. So relation to the defecation should be there, that should be stool frequency or form change should there. So either of these 3, 2 should be there to make a diagnosis, and it should be at least once a day, once a week for last 3 months. Criteria must be fulfilled for 3 months with symptom onset at least 6 months. Unless the symptoms are more than 6 months, you don't tell it IBS. If it is less than 6 months, we tell it some acute form of illness. But if someone has got 6 months or more, we call this as irritable bowel syndrome. So what is the current diagnostic and management? Establish a positive diagnosis. Always reassure the patient. Most important thing of your treatment is reassurance. Not that tell them that this is IBS, this is going to be staying with you for lifelong, you are not going to get benefit out of my treatment, you are not going to get cure out of this. These things don't reassure the patient. They put a negative impact on the patient that I am suffering from IBS. So this disease has this, so and so has this disease, he never got well. So never tell this type of thing. That always reassure that there is no serious organic disease or alarming symptoms. So this is a good thing that you don't have anything serious. Success of current treatment option in addressing multiple symptom IBS has been already limited. This is the Bristol stool chart. Everyone should be familiar with the Bristol stool chart. Unless you are familiar, you can go to the Google and find out what is the Bristol stool chart, because nowadays patients are smart enough to take their photograph of their stool and they are showing to in the clinic, sir, I am having this type of stool in my, I have taken this picture. So because last couple of days ago, I had a patient who had shown me this photograph. This is the 6 type of stool. You look at this. This forms the diarrhea. This is the chart showing IBS undetermined, IBS constipated, IBS diarrhea, and IBS mixed. So look at this, 25% on both sides undetermined. If it is a majority, it's diarrhea constipation predominant, this is diarrhea predominant. If there is not fixing the alternate diarrhea and constipation, you can call it IBS mixed pattern. This is the percentage of loose water stool, percentage of lumpy stool. So one should be familiar. 1 and 2 are definite constipation. 3, sometimes in Indian scenario, we call it as constipation, because in India, constipation definition is varying. People go 10 times to the toilet and still they'll tell patients that I am constipated. Unless he passes a good amount of stool, the frequency is immaterial to the patient, and he feels the whole day that I don't have a good bowel, and since morning he always worries or bothers that I didn't have a good bowel. So constipation in as Western world is less than 3 per week, but in Indian scenario, people consider constipation not the amount, at least they have to go 3 times a day or 2 times a day. Unless they have got a good bowel movement, they tell always they are constipation. So you have to find out whether it's really constipation or he is going to the toilet and passing normal amount of stool. So what are the differential diagnoses? Because once you think this is IBS, you have to exclude celiac disease, food intolerance, lactose intolerance, inflammatory bowel disease, infective colitis, SIBO, that's small intestinal bacterial overgrowth. Sometimes colonic diverticulosis, colorectal carcinoma, and giardia infection could be the contributory factor. So you have to find out by certain investigations that unless they fit into correct criteria of IBS, you make this diagnosis by certain investigations. So what is the newer diagnostic tool? Categorical Rome diagnosis, that's fine. Additional